All right, let's talk about a patient we've all seen. They come in with that recurring substernal chest pain. You've done the full workup, you've confidently ruled out a cardiac cause, so now what? It's a super common clinical puzzle, and today we're going to build a clear, step-by-step framework to solve it by focusing right on the esophagus.
So where do you even start? Well, the first place our minds should go is the esophagus. And why is that? Because for about half, 50% of patients with this kind of non-cardiac chest pain, the root cause is abnormal esophageal acid exposure. That makes GERD, or gastroesophageal reflux disease, our #1 suspect, right out of the gate.
And while we're zeroing in on the esophagus, it's really helpful to kind of zoom out and see the bigger picture. Look at this. Gastrointestinal issues can account for up to half of all outpatient chest pain cases. That's huge. It really puts into perspective why a GI-focused evaluation is so high yield once you've cleared the heart.
So here's our game plan. We're going to start by mapping out all the potential esophageal causes. Then, we'll hit the single most critical question that defines our entire approach. From there, we'll walk through two very different pathways, one for patients with alarm features and one for those without. And we'll wrap up with the diagnosis and next steps for those trickier cases.
Okay, first up, let's map out the esophageal causes. You can think of this as building our differential diagnosis. Lining up the usual suspects. Before we can figure out what the problem is, we gotta know what it could be.
So here are the key players on our list. GERD, like we said, is the big one, by far the most common. But we also have to keep esophageal motility disorders, functional chest pain, eosinophilic esophagitis, or EOE, and even something as simple as pill esophagitis on our radar. Each one has its own little signature.
Now let's compare two of the most common causes side by side, because this is where your history-taking really shines. With GERD, you're looking for that squeezing or burning pain, usually after meals, often with that classic heartburn. But for a motility disorder, the pain is more of a spasm. And the huge clue, the real giveaway, is dysphagia, or trouble swallowing, with both solids and liquids. That's a crucial distinction you can often pull out just by talking to the patient.
Okay, now we're getting to the pivot point of the entire workup. I'm talking about the critical question. Honestly, the answer to this one question is going to determine every single thing that follows.
And here it is. It's this simple. Before you even think about treatment trials or fancy tests, you have to ask yourself, are there alarm features present? The answer, a simple yes or no, is going to send you down one of two completely different diagnostic roads.
So what are these all-important alarm features? Well, think of them as the big red flags that tell you to stop and investigate further. Dysphagia or odonophagia, that's difficulty or pain with swallowing, could mean there's a stricture or some kind of obstruction. GI bleeding or anemia points to some real mucosal damage. And of course, unintentional weight loss is a classic warning sign we can never ignore. If your patient has any of these, it's time to get a more urgent workup going. So what happens when the answer is yes, and your patient does have alarm features? Well, that takes us straight down our first pathway, the approach for patients with those red flags.
For this group, the motto is investigate first. If you have any suspicion for something rare but serious like a gastric volvulus, you go straight to imaging. For pretty much all the other alarm features, the standard of care is an early upper endoscopy, ideally within 2 weeks, so you can get eyes on the esophagus directly. Now, if that endoscopy comes back totally normal, then you pivot and you start managing them using the logic from our second pathway.
Now, let's talk about the much more common scenario, pathway 2. This is your game plan for that patient who has esophageal-sounding chest pain, but absolutely no red flags. Here, the whole philosophy flips. We treat first. Why? We're leveraging the super high probability that this is just GERD. The move is to start an empiric trial of a high-dose proton pump inhibitor, or PPI, for a solid 8 weeks. If their symptoms go away, fantastic. You've likely found your culprit and you can start tapering the dose. But if the symptoms stick around, well, then it's time to dig a little deeper. And that brings us to our final section. What do you do when that initial trial fails? This is for those patients in Pathway 2 who didn't get better on the PPI, and also for the patients from Pathway 1 whose endoscopy was completely normal. But first, a really crucial clinical pearl to keep in your back pocket. Even if a patient does get better with a PPI, it's not a slam-dunk diagnosis for GERD. It turns out you can see a positive response in functional disorders too. So it's very suggestive for sure, but it's not definitive proof. Okay, so for those folks who don't respond to the PPI trial, this is your diagnostic toolkit. You can do an upper endoscopy to rule out any structural problems or esophagitis. Ambulatory pH monitoring is really the gold standard to actually measure and quantify reflux events. And finally, high-resolution manometry is how we formally diagnose those esophageal motility disorders we mentioned earlier.
So what if you do all of that? The endoscopy, the pH monitoring, the manometry, and everything comes back negative? What then? Well, you've just arrived at a diagnosis of exclusion, functional chest pain. It's defined not by what it is, but by what it isn't. It's chest pain without any of those other causes, and it has to fit specific time criteria.
And here's the key. The treatment for functional chest pain is a whole different ballgame. We're not targeting acid or muscle spasms anymore. Instead, the approach often shifts to neuromodulators, things like low-dose tricyclic antidepressants. The goal here is to target something called visceral hypersensitivity. You're essentially trying to turn down the volume on the pain signals coming from the esophagus itself.
So when you take a step back, what this whole journey shows us is a clear path from a broad complaint through a very structured algorithm to either a specific diagnosis or sometimes no clear organic cause at all. And that leaves us with a final, really important question to think about. When a comprehensive workup comes back negative, how do we shift our own approach and our patients' expectations from finding a cure to managing a chronic symptom? Making that transition, that's often the true art of medicine.